All right, so my name is Seth, and my presentation's on Osgood, Schlatter. So today our objectives are, I'm going to define Osgood-Schlatter's disease, and I'm going to refer to it as OSD from now on. I'm going to explain the pathomechanics and causes, describe clinical manifestations and functional limitations that present with it, identify key tests and measures for diagnosing, discuss differential diagnosis with similar conditions that have already been discussed today, provide an overview of rehabilitation phases and protocols, and then summarize all the things that we have talked about with likely outcomes and prognosis. So for the definition of OSD, it's a very common overuse injury of the knee. It affects adolescents during growth spurts mostly. The inflammation of the patellar tendon insertion on the tibia, on the tibial tuberosity, and it's most common in athletes just with running and jumping. So this is an apophysitis of the tibial tubercle. It's at the growth plate on the tibia of where the tendon attaches. And it's, like I said, it's the overuse injury and the pain is very localized. So for the pathomechanics, it is excessive stress on the patellar tendon. The tibial tuberosity is not fully ossified, so that growth plate is still open on those adolescents during their sport activities and whatnot. It's caused by repeated traction on the tendon because of the activities, physical activities during the growth phases. And it involves mostly muscle imbalances because that's what would be causing the traction of that patellar tendon on the tibia. So most likely it could be tight quadriceps, which could also be a factor of if you have adaptively shortened hamstrings that could put more mechanical strain on the quads to actually extend your knee. So that's why it would be more common with those muscle imbalances. And it's typically most common in boys aged 12 to 15 just because of their high activity lifestyles and the high impact sports that they do at those ages. So for clinical manifestations and functional limitations, you're going to have pain over the tibial tuberosity, the swelling below the kneecap. You will have like a visible bump on the tibial tuberosity, and the pain obviously is worsened with activity, especially anything with like the knee extension variety, tenderness with palpation, and then as far as functional limitations, of course, with it being partially named jumper's knee, it's going to have difficulty with running and jumping. You don't want to put weight on it directly with kneeling and everything. That's going to cause a lot of pain. It's going to reduce range of motion, especially with like the weighted extension. That's going to make it flare up a lot. And limited ability to squat or climb stairs, and inability to fully participate in sports. So with the pain that this is manifesting, it is very severe and continuous while the activity is taking place. It's going to be right at that bump where it connects to the tibia. So for the tests and measures, obviously you can take the range of motion of the knee because that's going to be limited. And you do the manual muscle test of the quad strength because that's what's also going to be affecting the patellar tendon as far as how much traction is being put on it. The special test would be patellar tendon tenderness test, which with that you would start with a patient in a supine position. You'll palpate their patellar tendon and see how much slack is in it. And then you'll bend their knee to 90 degrees and then also palpate again and see if that pain is reduced because of the change in position. So if the pain is reduced, then there's a positive test on the, some refer to it as patellar tendon tenderness test, and some say Royal London Hospital test, but that is the main special test to run for it. And then just to throw in as far as like the functional test, Dr. Carter was talking about, a 5-time sit to stand would be really good for this to see if that pain is exacerbated by that knee extension. You could even have them sit a little further on the edge of their seat to make sure they're focusing on their quads when they do it. And then imaging would be very important for this, so that you could see, like on this x-ray here, the actual tibial tuberosity does have some pathologies present and possibly even some fractures at that location. And you can see the patella is also riding a little high, so that would indicate that that tendon has been stretched at that point and they're having those issues. So for differential diagnosis, patellar tendonitis is going to be a big one that's going to be mistaken for this a lot, but they do present very similarly. It's an inflammation at the distal patellar tendon, but one of the biggest differences between this and OSD is the fact that OSD is for growth plates. So it's mainly for people who have not finished going through their growth spurts, and the pain is more localized distally as it is just in the patellar tendon itself. Now with Sinding-Larsen-Johansson syndrome, this is also with adolescents as well, but this is going to be pain that affects the inferior patellar pole. So the pain is going to be localized a little differently, and it's going to be exacerbated with a little bit different movements than OSD specifically. And then as we already learned about the meniscal injuries, so it's going to have like the locking, clicking in the knee, which is more unique to that and not as much OSD. And they're probably going to have more issues with exercises that involve compression and weight bearing of the knee rather than just knee extension itself. And then with ACL tears, that's going to provide that knee instability. So we learned about those special tests to differentiate those, like the anterior Lockman or anterior drawer test. So that's how you would see that instability, and you would rule out OSD if they were positive on those tests. So for the rehab process, all of these phases are very unique to the patient because for the most part, it completely goes away once the growth plate is closed. So it's typically not a long-lasting condition that they have to deal with. And typically once they have kind of stopped the activities that are giving them the most pain and kind of give it some time to adjust, then they usually go away on its own. But if you wanted to break it down into phases, obviously activity modification, so to take rest off of activities giving them pain, and then cryotherapy for that. So you do any sort of ice pack or compression sleeve, and then gentle stretching of the quadriceps, because like I said, that mechanical traction of the quads on the patellar tendon is what's causing that pain for the most part. And then isometric strengthening exercises. For the moderate protection phase, the progressive stretching of quadriceps and hamstrings, because remember the main component of this is a muscle imbalance causing that stretch or that traction. So like I said, the adaptively shortened hamstrings are going to be one of the main components of it. You want to avoid weight-bearing strengthening right at first, because you wouldn't want that to just cause more inflammation in the area. You would rather kind of work your way up towards that. And then soft tissue mobilization, so getting that patellar tendon kind of palpated and moving the patella around to kind of stretch those structures around it. And then minimal protection phase, you can return to sport-specific activities. The polymetric exercises where you're actually weight bearing and changing directions with dynamic exercises and agility training. But typically what it was talking about in Dutton is most of the time it works its way out once that growth plate is closed, but if there's no improvement within 6 to 8 weeks, they would advise immobilizing it with a brace to fully make sure that it is getting the rest that it needs. And then for likely outcomes, like I said, full resolution of symptoms after the growth plate closes. There is a risk of that persistent bump at the tuberosity, but once that growth plate is closed and your pain goes away, that bump is completely benign. It won't cause any more issues other than just cosmetic and possibly just the uncomfortable kneeling. And then, so of course, like you see in this x-ray, there is a risk that you might need surgery if it is bad enough to where you have an actual fracture, like it pulls the tuberosity off the tibia itself. But most patients return to full function with not a extensive amount of therapy. And they all make gradual returns to sports once they're pain-free. So in summary, we went over the definition of Osgood Schlatter's disease, the pathomechanics and causes of OSD, clinical manifestations and functional limitations, the key tests and measures for diagnosis, the differential diagnosis and how the other pathologies will present very closely to it, the rehab process and the likely outcomes and prognosis. So these are my references. Does anyone have any questions?
Did I get diagnosed with this when you were younger?
I did.
You did? You still have your residual bump? Your persistent bump?
Not as much. I still have patellar tendonitis, but it's not as much of a bump.
I got diagnosed when I was younger. I still got mine.